Hello, everyone. I'm Dr. Meganath Yenny. Today, we're going to dive into the new 2025 IDSA guidelines for complicated urinary tract infections. My goal here is to really simplify these updates and turn them into a clear, actionable framework that you can start using right away in your clinical practice.
So here's our roadmap. We're going to follow the logical path you take with a patient. We'll start with a brand new way to classify UTIs, which is a crucial first step. Then we'll see how that dictates our antibiotic choice, how we can refine that choice using a 4-step plan, and when to de-escalate. We'll wrap up with the new, much shorter treatment durations and, of course, some important exceptions to the rules.
All right, let's jump right in with what is really the foundational change in these guidelines. The first, and honestly the most critical step you'll take, is classifying the UTI correctly. Getting this right from the very beginning is going to shape every single decision that follows. Now, this is a pretty major shift. The guidelines are moving away from classifying based on host factors, like, say, whether a patient has diabetes. The new distinction is much simpler, and it's all about anatomy. A UTI becomes complicated as soon as the infection moves beyond the bladder. So what are you looking for? The key indicators are those systemic symptoms: fever, chills, flank pain. If the symptoms are purely local, it's uncomplicated. Simple as that. Okay, so you've identified a complicated UTI based on those new criteria. The very next question, the one you need to answer immediately, is which antibiotic do you start? This is what we call our empiric choice, the therapy we get going before those culture results are back. And the guidelines make this incredibly straightforward. Your decision boils down to one single pivotal question: does your patient have sepsis? This is the most important fork in the road you'll encounter when selecting that first antibiotic. The rationale here is all about risk. In a patient with sepsis, the number one priority is immediate, effective, life-saving coverage. That's why we're justified in using our broad-spectrum agents like carbapenems. But in a non-septic patient, the mortality risk is way lower. So here, the priority pivots to antibiotic stewardship. We want to reserve those broader agents, which means we should avoid carbapenems as a first-line choice.
And this is a really critical point. Two very common outpatient UTI antibiotics, nitrofurantoin and oral phosphocylline, are specifically not recommended for complicated cases. Why? Because they just don't achieve therapeutic concentrations in the kidney tissue or the bloodstream. That makes them pretty much ineffective once that infection has traveled up beyond the bladder.
So now that we know the major classes of drugs to consider, the guidelines give us a really helpful, structured framework. It's designed to help you refine that initial choice and select the best possible empiric agent for your specific patient.
It's a clear 4-step process. First, you assess the severity, sepsis or no sepsis. Second, you evaluate that patient's individual risk for resistance based on any prior cultures or antibiotic exposures. Third, you've got to consider patient-specific factors like allergies and potential drug interactions. And fourth, and this is absolutely crucial for septic patients, you must consult your local antibiogram to make sure you're getting adequate coverage. Let's just zoom in on that second step, resistance risk, for a second. The guidance here is very direct. You want to avoid any antibiotic that has previously documented resistance for that patient. And if a patient has taken a fluoroquinolone anytime in the past year, you should avoid that entire class for empiric therapy because the chance of induced resistance is just too high. And for step 4, when you're dealing with your highest risk septic patients, that local antibiogram becomes absolutely essential. The guidelines give us specific thresholds to aim for. For a patient in septic shock, you need to choose an agent with at least 90% susceptibility. For sepsis without shock, the target is at least 80%. This data-driven approach really maximizes your chances of getting the initial therapy right. Okay, so your empiric therapy is started. Now we wait. As we get more data from the lab, we move into the next phase of management, which is all about adapting our treatment based on that new information. Usually, within about 24 to 48 hours, you're going to get that call. The urine culture and susceptibility results are back. This is the key moment where you can pivot from that broad, empiric coverage to a much more precise, targeted approach. This practice is called de-escalation. It simply means switching to the most narrow-spectrum, effective antibiotic that the culture results point to. This is really a cornerstone of modern antibiotic stewardship. It's better for the patient, it reduces the risk of side effects, and it's a huge help in combating the larger problem of antibiotic resistance. Part of refining therapy also means transitioning from IV to oral antibiotics when it's safe. The criteria here are very straightforward. 1, the patient is clinically improving. 2, they can tolerate taking medication by mouth. And 3, an effective oral option is available based on those susceptibility results. Making this switch is great because it reduces catheter-related risks and can help get your patient home sooner and safer. So, we've chosen our drug, we've refined it. The last major clinical question is, how long do we actually treat for? And this is another area where the new guidelines have made a very significant change. This is probably the single biggest practice change in the entire guideline. For patients who have a complicated UTI and associated gram-negative bacteremia, the new standard of care is a total of just 7 days of therapy. That's a dramatic cut from the traditional 10 to 14 days we used to use, and this change is strongly backed by recent trial data showing that shorter courses work just as well. And for patients without bacteremia, the durations are also nice and short. If you're using a fluoroquinolone, a 5 to 7 day course is plenty. For any other appropriate antibiotic, the recommended duration is a flat 7 days. Now, of course, there are always exceptions. A longer course of 10 to 14 days is still something you should consider in certain situations. For example, when you suspect acute bacterial prostatitis, or in patients with severe sepsis or significant immunocompromise, or if there's an unresolved source like an abscess or an obstruction. And here is a really crucial detail to remember in your practice. The clock on that treatment duration, whether it's 7 days or 14, it starts on the first day the patient receives an effective antibiotic. That means an antibiotic that the pathogen is actually susceptible to. It doesn't start from the day of admission if your initial empiric choice turned out to be wrong. Okay, to wrap things up, let's touch on that critical scenario of treatment failure. What's our game plan when a patient just isn't improving the way we'd expect, even on guideline-directed therapy? This is such an important clinical question. You've followed the steps, you've chosen the right drug, but 48 to 72 hours later, your patient is not getting better. What do you do next? Well, the guidelines provide a fantastic 3-point reassessment checklist. First, you have to ask, is there a drug-pathogen mismatch? Second, you need to actively look for an unresolved source, like a hidden abscess or a urinary obstruction. And third, you have to be willing to reconsider the diagnosis entirely. This systematic approach really ensures we don't miss something critical in these complex cases. Ultimately, these new guidelines push us all towards simpler classifications, smarter, risk-based choices, and shorter, evidence-based treatment. Thank you so much for joining me.